You might have to leave as well. I think I thought I maybe mentioned that, or if I forgot, forgive me. Okay, so just then in terms of declarations of interest, we have our normal register, but is there anything on the agenda that people specifically want to declare? I don't think there will be. No. Okay. So just the minutes then of the last meeting, which was the meeting that we had on the 15th of July. Just in terms of accuracy, I mean, obviously there's quite a number of pages there, sort of 9 in total. Is there anything within there accuracy wise that people want to pick up on? Or are we happy to accept them as a true record? Okay. Is everyone okay? I'll say Carol, yeah, go ahead.
Just on page 4,
Okay.
It's not so much accuracy, it's just making sure that it's quite clear. On the bottom of page 4, Ed updated us on the vaccination process. As of 13th of August, 89% of people in North Cumbria had their first vaccination. I'm assuming that's 89% of over 18s. And I think
eligible. Yeah. Good spot, Carol. Yeah, it's eligible patients. Yeah.
Good point. Thanks, Carol. Brenda, have you got that? Yeah, thumbs up.
Yes, thank you.
Yeah, thanks for that, Carol. Right, okay, so happy to accept those as a true record with that minor amendment. So I'm going to go straight into this. There's 2 items here on 4. One's the COVID-19 update. There's a couple of things there, obviously current position and antibody testing, and then we're going to move on to the vaccination process with yourself, Ed. And is anything as well in the wider vaccination process that you might be able to tell us about flu? But I know, are there any presentations, or is this just a verbal update? It matters not. I just want to make sure. So, Peter, just a verbal?
Just verbal.
Yeah, and Ed?
Just the same.
Yeah, okay. No, that's fine. So, again, it's if we can, just to try and restrict it to the pertinent points, I'd be very grateful. But I'm going to hand over to you first, Peter, for the current position and then the antibody testing.
Okay, thank you. Just to forewarn, Chair, I'm unclear what the antibody testing issue is, so you may need to clarify that for me.
All right, okay.
Yeah.
Okay, thank you.
In terms of the overarching position, in summary form, so as governing body members are aware, regular meeting of the Health Protection Tactical Group with a continuous review of case rates, testing rates, positivity rates, and so on, chaired by the Director of Public Health, and the Cumbria case numbers, including by District Council, are published every Friday. So that's in the public domain and available every week. Across England, the case rate has been reasonably stable at about 300 per 100,000 people per week. 300 new cases per 100,000 people per week. And the national R rate is reasonably stable, somewhere between 0.9 and 1.1. They are actually still high case rates. So relatively stable, but it is high. And Cumbria, over the last few weeks, has been higher than the national average. Normally, about 4 or 5 of the district councils above national average rates. And Cumbria has been between 350, 400 kind of level per 100,000 per week. Typically lower than the Northwest average, but higher than the England average. So still significant attention to case numbers. The case rates by far are highest amongst the school age population. That may partly be a function of the testing and surveillance arrangements in schools, particularly for children returning to school after the holidays, but by far the highest in both the 5 to 12 and 12 to 18 age group. And then significantly lower in the working age adult population, and thankfully lower again in the kind of retired age groups. Although there has been a recent rise actually in percentage rates amongst some of the most elderly age groups, which is clearly a cause for concern. Just by reminder, in the peak of new cases, Cumbria approached 700 in the January period and was heading towards that by early, over the summer. So the cases have continued to go up really since July, but relatively stable. In terms of the impact that has on severe disease, again, at peak in the third week in January, one day there were over 200 people in our North Cumbria hospitals who had a positive COVID test. Since March, so since the end of March, so April onwards, that number's been less than 50 and significantly less than 50 for most of the period. And the explanation for that really is the effectiveness of the vaccine programme. So I know you all know this, but for the purpose of avoiding all doubt, without equivocation, without question, without doubt, without dispute, the vaccine programme has been highly effective at protecting the population and reducing the link between case rates and severe disease. It does only reduce the link. And we still have an unvaccinated population, and there are some people, for various physiological reasons, where the vaccine is not 100% effective in any regard. So big reduction in people who would otherwise have been in hospital, and inevitably that means a big reduction in the mortality we would otherwise have seen. In terms of mortality, this always feels very grave, doesn't it? But across Cumbria, across the whole of the county, since the beginning of the pandemic, over 1,500 people have lost their lives with COVID. It's a very, very significant mortality toll in that regard. For this calendar year, excess mortality is clearly observable compared to the 3-year rolling average, excluding the beginning of the pandemic, because that clearly skews things. For the 3 years before that, the mortality rate is significantly higher, which is not solely explainable from the COVID-related deaths. So there are other impacts going on. Of course, there are variations year on year naturally anyway. So we should be very respectful. Sadly, people have had severe disease and a considerable number of people have lost their lives. I'll hand over to Ed on vaccine, but the vaccine numbers in North Cumbria are now, and largely always have been, higher than national average and higher than comparable areas. And that's partly a testament to the way that the people of Cumbria have engaged in the vaccine programme and come forward when they've been asked to. Some people had to show considerable patience. It's been very difficult for some people who felt that they should have had access to the vaccine sooner, people with legitimate concerns about vaccine reactions and so on. But the public has responded in a astounding kind of way to the vaccine programme being delivered. And all the colleagues in primary care, including general practice and pharmacies, actually, our secondary care colleagues, all the support we've had from third sector organisations, local government, everybody, has been deeply impressive. From recollection, Cumbria is at about, for the 18 plus population, of course, the denominator changes when we include the 16 plus, but 18 plus population, I think we're at about 93% first vaccine, 86% second vaccine. Astounding numbers, really. But I'll hand over to Ed. I thought you weren't able to join us, Ed, so I was prepared on this, but I'll hand over to you just to go over where next with the vaccine programme, because for those of you with electricity in your homes, you will have noticed there have been some big announcements this week, which Ed and the team are busy trying to work through, which is why Ed might not be able to stay for the whole meeting. But Ed, do you want to summarise those?
Thanks, Peter. Thanks, John. So yeah, the figures are very impressive and are highly comparable, as Peter says, both nationally and regionally, for all the reasons that Peter gave. So that's phase 1 and 2. The numbers of vaccines per week is there's about 500 first doses that are now trickling through per week, and there's about 2,000 second doses per week that are kind of starting to finish off that phase 1 and phase 2 process. In addition to that, we're doing a final squeeze, if you like, on the groups of people that experience inequalities within North Cumbria. So we now have a roving model that we deployed to Carlisle College last week. And for those of you that support Carlisle United, you'll see it at the Carlisle United ground on Saturday. And then we will then be planning a number of rollouts to community centres and big employers within North Cumbria and some of those areas where we know uptake isn't so great, e.g. Alston Longtown and some areas of Carlisle. So the roving model is allowing us to really start to reach out, take the vaccine to the population for those areas where we can really be sniper-like in our approach by using the data that we've got to say these are the areas where uptake's not been great. It's a final squeeze. There will be small numbers. There will be people who are going to take longer to vaccinate because the likelihood is they will be more hesitant or more wary or need more convincing. So tiny numbers, takes a lot longer, but really demonstrates that within North Cumbria, as Peter said, all stakeholder partners are working really hard to make sure we do as much as we possibly can to get as many people vaccinated. So that's phase 1 and phase 2. Phase 3, which is the over 50s, which will start, well, we're told will start on Monday. We don't have any vaccine yet, but apart from that, don't worry about small issues like that. From Monday, the phase 3 over 50s program will roll out. And once again, it'll roll out in cohort order. So it'll be the over 80s, health and social care frontline staff, those that have vulnerabilities, etc. So that will be rolled out over the next probably 12, 13 weeks. It looks like, and it's not been confirmed yet, that we'll be using the Pfizer vaccine on that one, solely the Pfizer vaccine. But there is there's a meeting at 3 o'clock, which is a regional meeting that I'll have to go to. Then there's a national meeting at 4:30 today, which is a national webinar from the national team telling us exactly what's happening. And then there's a North East and North Cumbria Vaccination Board on Friday afternoon. So I know that colleagues are being briefed regionally with all of the operational detail following the announcements from Boris and his team on Tuesday this week. So that's phase 3. So that will be starting imminently. And alongside that, there was the announcement a couple of days prior to that around 12 to 15s who are now going to get one jab. The school nurse team in North Cumbria are leading on this, but because this is now all coinciding with the rollout of the biggest ever flu vaccination campaign that the UK has ever seen, the school nurse vaccinators are almost wholly taken up with the flu vaccine programme, which means that we're now working with community pharmacies and others to find vaccinators for the 12 to 15 plan, i.e. going out to schools and vaccinating the 12 to 15 cohorts. There's lots of complicating factors around consent and particular hesitancy in terms of, you'll have seen on the news this week around what's the risk benefit for 12 to 15s. It's quite marginal. So I think the expected uptake is going to be a lot poorer than we've seen for all of the other groups to date. And I'm hearing figures between 50 and 75% expected uptake. So that's the COVID vaccination programme. And then obviously flu, as I say, that will be kicking off very soon as well. That's complicated by a number of factors, some being deliveries being delayed on the whole. There are several manufacturers where orders went in from community pharmacies and GPs probably nearly a year ago. Now that we're going to be vaccinating more people, there are some concerns about ongoing supply and whether there's going to be enough flu vaccine in the system, and this is a UK issue. So there's a lot to still play out with both the COVID and the flu vaccination programme over the next few days and few weeks. But as Peter said, the input from all stakeholders in North Cumbria has been outstanding. That continues to be the case, and I have every confidence that we will work through it together and deliver an optimal programme. Happy to take any questions.
Okay, thanks Ed, thanks Peter. Just wanted to sort of quickly touch on this the bit about antibody testing, Peter, that is on the agenda. It's just basically just awareness of the UK Health Security Agency's launch of the antibody surveillance programme for the general public, where they're going to make test kits available for up to 8,000 people today and sell 8,000 people a day just to self-register, just so they can understand obviously the protection provided by antibodies generated during COVID and the vaccination programme. It was as simple as that, and it was just to raise awareness of that. That was all, particularly as a public meeting. Yeah.
Apologies, John.
No, sorry, don't worry, Peter.
I should have realised that's what you were referring to.
It wasn't clear enough in the thing, so that's fine. Okay, so I've got 3 hands up. I've got Deb, John, and Peter. I'll start with you, Peter, obviously, because it's something you may want to add in terms of anything that you've just spoke about.
Just briefly, clinical colleagues are much better qualified to comment on this than I am. Of course, the presence of antibodies isn't the only indication that you have a physical protection. You know, the action T cells, etc., probably just as important. So, but moving on, the other thing that I wanted to reflect, really, Chair, is that's kind of the current COVID and vaccine position. But of course, we have a very significant legacy from COVID now. So lots of people who have had delayed, deferred or disrupted treatments, people who've had changes in their health-seeking behaviour, the impact of being very socially isolated on emotional well-being and indeed physical well-being, muscle functioning, etc. Lots of people, a very high number of people, as reported nationally, awaiting elective care, and some of the ongoing challenges for the health and care system around working in the most COVID secure environments that can, and the extra time and care associated with infection prevention control, etc. There are also the broader societal impacts around changing the labour market, again featuring quite prominently in the national news this week about what that's meant for people in social care, for example. And lots of changes for families, all of which means that although the number of people with severe disease, thankfully, is relatively low, clearly a huge impact for the people who do experience that, which I wouldn't want to diminish. Despite the severe disease numbers being relatively low, the impact from the pandemic is still enormous, hence the long-term recovery implications for everyone. So I just wanted a quick reminder of that point, Chair, but I'll stop there.
Thanks, Peter. Okay, I'm going to go with Deb and then John.
Thanks, John. Just 2 things. One, to say thank you very much to the vaccination teams within Cumbria. You've done a lot to keep the Cumbria population safe. And I wondered if you were going to be putting out a call for volunteers again. And the other thing is perhaps to highlight what was in the news last week, that only 1% of those with severe illness had not been vaccinated. And I think that probably needs to be sort of added to the comms, Julie, because I think it will encourage those who have still not got vaccinated. But thank you very much for all your hard work keeping us safe.
Thanks, Debbie. Is there anything else, Ed, do you want to mention on anything there about the volunteers? Or
so the PCNs and the community pharmacies have a network of volunteers that they will reach out to. We're also really closely linked with the Health Protection Tactical Group, which is a whole lot of partners across North Cumbria who, whenever we get stuck, seem to be able to help us out in one way or another. So yeah, volunteers are very much part of this programme and will be on an ongoing basis.
Thanks, Ed. Okay, John.
Thanks, John. I'd like to say a thank you to all the staff for all the work they've done. And I mentioned this earlier in the year, Ed. There's 2 points to my question. There's one is you've touched on the capacity of the team to deliver going forward and how you're trying to address that. Just wondered about the welfare of the team and what arrangements are in place to support them, because it must be a bit of a slog, especially if you reduce flu as well. And my other point was about, I know today, I believe today is the first day that care home staff have to be vaccinated. I just wondered what your insight was into the levels of vaccination in care homes.
Thanks, Thanks, John. I'll just take those in reverse order, if I may. So when we first went round to care homes, the uptake for both care home residents and care home staff was really high, so it's in the kind of 90%. I do have a call in with local authority with Derek Houston to address that issue in terms of how many do we think are unvaccinated. And obviously from a local authority point of view, there's a lot of work going on looking at workers within care homes and what the significant impact that might be if they remain unvaccinated. We all still have an evergreen offer, so people who are unvaccinated will still be able to get vaccinated. So the offer, even though it's been offered once and people have said no, is still there. So those that want can still get, and we'll make sure that that's a really clear message. I'm sure Julie's going to add to that one. In terms of welfare of the team, I don't know, is Mandy on? I mean, she's our
Mandy's not here, Ed. She's giving her apologies.
I think it's a good point, John. I don't really have an answer in terms of, I think the demand in primary care is huge at the moment. So, you know, we're hearing nationally that there are some concerns about people having access to their GP practice, even though they have remained open throughout and still offer face-to-face appointments. And some of it comes back to Peter's point in terms of post-COVID. What does the new normal look like in terms of patients' expectations around what they expect from their general practice versus what we've learned from the pandemic in terms of the use of digital technology, etc., and the ability to potentially see more people, even though it might be through triage or through digital means rather than face-to-face. So I think those are some of the comms that we're trying to come to terms with and working with Julie on. In terms of welfare, I think it's kind of a keep going and carry on type of mentality at the moment, John, to be honest with you.
Okay, thanks for that, Ed. Julie and then Helen.
Yeah, I was just going to say, I think it's a really helpful point from Deb around trying to encourage uptake by understanding the real impact of vaccination and how it does reduce your chances of becoming seriously ill. Just to flag up, we've got a flu vaccine which is now underway in some practices but not in others at the moment. We've got 12 to 15s who will be eligible for the jab, but they'll be getting that through their schools team. We've got people already ringing their GPs asking if they can book in for their COVID booster. We've got a lot of quite difficult messages to get out to the community so that they can understand what the process will be. We've done a bit of work this morning sharing messages around, please don't ring your practice because they can't book you in. We'll be following those JCVI cohorts. Actually, it took us from January to March to get through them first time round. There's a good chance it's going to take that long again. So there's a lot around expectation and understanding of the process that we'll have to work through, but it's going to take a lot of support from partners for us to be able to keep repeating that message so that people understand and don't add unnecessary pressure into the system while they are quite rightly anxious about when they're going to get their booster. So there's lots of thought going into it, but it feels like a very difficult message. It's quite complex and very easy to misunderstand, I think. Thanks.
Thank you, Julie. Helen?
Yeah, it was just to go back to John's point. Excuse me, John's point. I think welfare of the vaccination teams is absolutely paramount, but I would also echo Ed's point. I think it's widespread. We need to be looking at the welfare of all of our staff, hospital staff, primary care staff, community, everybody. But speaking from a primary care perspective, we have the vaccination programs ongoing that we either are doing with flu or contributing to with COVID. We have the COVID recovery work that we're doing, the business as usual work. But also we're now starting to see the onset of winter coming. Schools going back. I can see a couple of people who are snotty-nosed and full of cold on this. We've been seeing a lot of that in primary care. So we're starting to see those children coming back in with their respiratory illnesses that they haven't had for a year because everyone was in isolation. The infective disease, gastroenteritis, all of that is starting to pick up as well. Primary care is very pressured, very busy. I do worry significantly about the welfare of all primary care staff, not just doctor staff, but all primary care staff, frontline and non-clinical as well. And I think part of what we have to look at how we support the welfare of those staff. part of that is about the messages that we get out there, and I think some positive messages going out about PrEP. There's been a couple of brutal weeks for GPs and primary care in the media, and that reflects in how people then deal with practices when they are calling about their COVID vaccine, which they can't get through the GP, etc. So I think we need to work really hard on some positivity coming out, because that positivity will then reflect into support for services which will help their welfare. At the moment, primary care is feeling pretty battered from many directions. So I echo your point, John. I think it's wider than vaccinators, and I think staff welfare, it should be one of our paramount concerns over the next few months.
Okay, thank you, Helen. I'm not seeing any more hands. I was going to draw a line under that part of the agenda. Thank you so much, Peter and Ed. And as I say, when I talk about the team, this is such a widespread team of people who are dealing with this, you know, right across North Cumbria and right across, obviously, the UK as well. So thank you, everybody, for that work. I'm going to go on to item 5. And Charles, I'm hoping the answer is going to be nothing, but I'm going to leave it to you to let us know formally.
Yeah. Well, this is the strangest item ever, because this must be about the, I don't know, 10th consecutive governing body where it's come up. But you are right that we have not taken any such decisions. I think maybe just to think about for the next meeting, I think we extended, I can't quite remember off the top of my head how long we extended these rules for, and although we haven't used them to date, I'm not expecting them to, but given what we've just heard about winter organisational change, etc., I think there may be some merit in just extending them to the end of the financial year, just to be expedient. Hopefully they won't be needed, but then we've got that just in case.
Okay.
But I'll pick that up with Brenda for the next agenda.
Okay, thanks, Charles. Appreciate that. Okay, I'm going to move on to yourself, Mark, chairing Accountable Officer report, just to take through some of the particular points that you want to pick out in there.
Thanks, John. So first thing is in terms of the ICS. Hopefully, as the members of the governing body will be aware, we're now starting to see a relatively regular flow of guidance coming through, and I think that's really helpful. I think there are still a number of concerns about the timescales and how those timescales are getting concertinaed towards the end of March, but nevertheless that is helpful. The most recent guidance that we've seen is in terms of more information about place-based working, more guidance around working with voluntary, community and third sector, which I think is really helpful, and also some more guidance around clinical input into the new ways of working and the ICS and place-based working going forward. Again, very, very helpful as well. The major focus at the moment is in terms of the design of the ICS, and Sir Liam Donaldson, who is the chair, and Alan Foster, who is the executive lead. They're working on a range of meetings at the moment with local authority and NHS leads to be able to come to some consensus and conclusions about those. And probably the most high profile work going on is around the recruitment processes which have been started, and the chief executive recruitment process has started, and we expect to see other posts start to be filled later in the year as that moves forward. So in general terms, things are starting to move forward there. We also made note for members of the fact that the CCG annual assessment process has gone through this year, and it's different to previous years. Remember, in previous years we have received a level, and the last time we were assessed as good. This year it was a discussion, and we have received a letter, and hopefully you've seen the link to that letter, which is about assurance about how we have performed during COVID, and it has highlighted a number of particular areas. Well, one in particular, very good practice, best practice in terms of the way that we've dealt with inequalities during our vaccine programme, which we've just had quite a long discussion about. There are a number of bits of work going on at the moment that help take us forward in terms of the way that we work at a place-based level. One of those is about our review of working relationships with the third sector, which I think is really important. I think we've got really, really good relationships with our third sector. But in order to be able to move to new levels and next steps, we're going to be doing some more work around that. We've also got our annual general meeting coming up as well, and given the success of last year where we held that jointly with North Cumbria Trust, we are proposing to do the same thing again for this year as well. So hopefully that will be an informative and helpful event for people, and I think we look forward to that coming up. In terms of some of the developments that we've got going on, so while we are focused on all of the work that's going on, the vaccine programme, etc., we continue to push forward as a system with developments, and it was really welcome to see Sajid Javid, the Secretary of State, come up to Cumbria at the opening of the Cancer Centre, which is being run by colleagues in Newcastle. Again, a very, very welcome development in lots of different ways, both in terms of providing services for our public patients and access and quality, etc. But it's also a very visible programme, and it does help in terms of confidence for our community and confidence that we are moving forward with various developments while we are continuing to deal with the challenges that we are. We've also had the ground cutting ceremony for the GP-led health centre for Carlisle Healthcare Primary Care Network, and we look forward to that facility opening. I think it's in summer or autumn 2022. So lots and lots of good news there while we deal with some of the challenges. But I do just want to spend a little bit of time thinking about some of those challenges, and we are in the process of doing winter planning. But as Helen has already quite clearly highlighted for us, it already feels like winter in lots of ways, in terms of the demand for care in primary care in the community, the demand for care in our trust and in mental health as well, and also the demand for care for local authority colleagues in terms of packages of care for people being cared for in the community. And it does feel like a very, very pressurised position at the moment. More like winter than summer. It's not inconsistent with what colleagues are dealing with in the rest of the ICS. And in a lot of ways, the rest of the ICS is starting to see some of the issues that we are dealing across here and have dealt with for some time, not least in terms of care package availability out in the community. So some of the things that are going on around that, obviously, as you can imagine, there is a huge amount of focus on it. I've been chairing some escalation meetings for the last 3 or 4 weeks. Our LRF, Local Resilience Forum, was brought into place to meet at the behest of the local authority to consider how we might tackle some of the packages of care that we haven't been able to provide, or the local authority hasn't been able to provide out in the community. And there's a lot of work going on around that as well. Everybody is doing everything that they possibly can to try and sort some of these issues out and sort some of the patient flow issues out. It is exacerbated by the fact that while we're not only trying to deal with that, we're also trying to deal with putting the elective recovery system back in place and get more people going through hospital. There are particular areas of pressure. The Rowanwood facility has closed. So there are particular areas in the mental health side of the equation as well. And I think wherever we look, that there are challenges. I think it's really important to note what Helen said. People are getting very tired. And the demand for services is certainly not going away. So there are lots of things for us to continue to consider, not only in terms of how we continue to provide care for our public patients, but also how we care for our staff as well. Peter, I didn't know whether there was anything that you wanted to add in terms of any of the detail around the pressures at the moment.
I think you've described the situation really very clearly, Mark. It's been a very difficult summer. The only thing I wanted to add, really though, was from a public perspective, because the NHS is still open.
Absolutely.
So if you need us, come forward, please. But we would be encouraging the public to be aware that in some cases there will be a delay, and where you still need to wear face coverings, please don't bring the whole family to A&E. Those kind of things would really help. And of course, for the vast majority of the public are incredibly grateful for the services that the NHS and partners give. But also a reminder, just be good to these staff. We're trying to look after you. It can be really frustrating, can't it? We've all been there when you wait a long time or you feel that you're not getting the service you deserve, but be respectful to the staff. But please, the NHS is open and we will always be doing our best that we can. But people will need to realise that, sadly, in many cases, there will be delays and they will be offered services perhaps in different ways to how they used to receive them. So a bit of a tricky message for everyone in the public, really. But please don't think the NHS is too busy for you, because we're not.
No.
Thank you, Mark and Peter. I'm going to go to you first, Carol, and then I'll kind of see what we've got in terms of other people's questions. Go on, Carol.
Thank you very much, Mark, for the report and also for the additional information about the pressures. And for the assurance, actually, that you feel as the accountable officer that we are doing everything that we can, both as a CCG and as an NHS system, and that we also have our wider system kind of tied into having a whole society response, or whatever you want to call it. So that's really pleasing. But we do have these very serious demands, and the performance report that we're yet to get to does. It's a bit of a grim read, really, in terms of our constitutional targets and the sheer numbers of people that are waiting, despite all of our efforts. And so that was more of a comment, I guess, on what you've said. And we really need the public, as you've just as Peter's just highlighted, to be with us here, both in terms of understanding, I think, what the current position is in the NHS, and it's not just in Cumbria, it's nationally, isn't it? And what they can do, some specific messages about what they can do. So I was wondering if Julie maybe could comment on what we could or are doing in Cumbria to help to, firstly, about the delays, and secondly, about how the public can support us. And then also if there are messages that we want to send to staff as well, how is that being handled, about they're so tired, the ongoing support to staff is a real concern. So thank you very much.
Thanks, Carol. Julie, do you want to come in there?
Yeah, I'm more than happy to. As you can imagine, we've spent a lot of time discussing this, and it is a real challenge. And one of the things that I'm really aware of is that if people are poorly and need to be seen, then we must not put them off. And quite often the people that will read those messages about everything's under pressure, you must only really go if you really want to, are the ones that actually might need to be going to A&E. Perhaps the people who use it in a different way won't even notice the messages, won't read them. So that there's a real balance about not putting people off who need medical help because they're worried they're going to be a burden on the system, but also being really clear. And one of the things I spent a lot of time discussing with colleagues is the need to provide a clear call to action for people. So to tell people what they can do instead, not just say don't come. And there's a bit of work going on across the system to try and work out how we can do that effectively. So there's, again, no easy answers to this, I'm afraid. And the reality is it's an operational challenge which needs an operational solution. But we'll do all that we can. One of the things that we're talking about specifically around primary care and the pressures on GPs that we've already talked about a little bit is going to our West Cumbria Community Forum this week to say, actually, we think a lot of the messages that people are getting are that GPs have been on the golf course since last March and they're just not bothering to see you. But the reality is that actually they've been doing vaccine rollout, they've seen people face to face all the way through. But the reality for a patient is they might need to do that 8 o'clock dash for a phone call for 3 or 4 days before they can get an appointment. And there's something about understanding the frustrations for the patients, but also trying to tell what the story really is. So we're trying to do that, but we're trying to involve people helping us to make sure that we don't crassly step all over them and just make the situation worse. Open to any ideas as well. So if anybody thinks of anything or is aware of anything they think will be helpful, please let me know. Okay. And thank you to David for letting us jump into the Health Watch conversation on Friday to talk to the community group about that as well. Much appreciated.
Thank you, Julie. Louise.
Yeah, I was just going to add, I suppose, some figures that were quoted recently that we've probably referenced here before, that on an annual basis, there's about 24 million A&E attendances, but in primary care, it's 300 million per annum. So even if there's a 1% shift from A&E into primary care, the impact is going to be significant. So I know they're sort of high level figures, but I think probably indicates part of the the challenge certainly that primary care is currently facing. Thanks.
Thanks, Louise. Are there any more sort of questions or points on that particular subject before we okay? Right, and thanks for raising that, Carol, and thanks for covering that as well, Mark, within your report, or our report, sorry, I shouldn't sort of do it that way. I just want to say a couple of things, really. One is I did reference it before we started the meeting. I just wanted to note down in our minutes the recent nominations that we've got for the Chris Buckingham Award, and obviously everybody will remember Chris in terms of the award and who sadly died, but also for the fact that the award is for going above and beyond. But I wanted to note that the nominations that we've had for this quarter were Catherine Poxon, and Catherine works in the Next Continuing Health team. There was the communications team. Well done, Julie and the team. You know, and the fact that people were nominating yourself and your team. There's also the corporate team as well. And again, I know Brenda and Pauline are on this, so thank you for that. And finally, there was Karen Murray, is a senior locality nurse in relation to personal health budgets. I will be visiting you all, as you know, because I've made contact with you. But I just wanted to say, you know, a thank you to all the work that everybody does, but particularly for those 4 individuals in memory of Chris. And I did spend a lovely time with Karen yesterday presenting her award at her workplace, which was actually at this point in time was at her home, but it was really nice to see her and find out a little bit more about what she's done and thank her personally for that. And so the other thing I wanted to mention is it's not Sue Stevenson who's cutting the sod at the bottom of the for the new healthcare practice in Carlisle, but I did want to make mention that Sue was obviously an attendee for us on behalf of Health Watch. We've got David here, so thank you for your attendance, David. But I wanted to make sure there was reference made to Sue and her commitment to us as a governing body. And her commitment to this area as well, in terms of North Cumbria and Cumbria. And actually, she was very instrumental in supporting us through the Healthcare for the Future. Now, I have written to her specifically, and I've made personal contacts with her. I know a number of colleagues have as well. But I just wanted to mention that in terms of this particular meeting. I know it's on the report, but I just wanted to make my own personal thanks and mention to Sue for her support. Okay, I don't think we've got anything else on there. Is everybody happy for me to move on? Yeah. Okay, I'm gonna shift on to yourself, Colin. And again, it's not a good story. It's about blood bottles, and I know this has been in the national news as well. But Colin, just to give us an update as to where we are with this situation, please.
Thank you, John. Helen Horton may also
okay,
be saying something. The first thing to say is that this is a highly operational issue, and in other words, we're right into the nuts and bolts of how you provide services. So here we are to support service, laboratory support service, and basically, if things aren't in place very quickly, the service you provide has to be affected by that and even managed. So within the last few months, the ability for this country to supply BD vacutainers, or blood bottles if you wish, has been affected. Now you can Google that and search your heart content to try and work out why, but suffice to say it's a combination of being able to source the constituents they need from around the world, and how their factories work and what maintenance the factories to go under. So very quickly, there was an effect on the system. So some of you might have heard of just-in-time supply systems. The idea is that you do not have warehouses full of things just waiting to be used, but you produce or deliver equipment needed close to or almost immediately on the same day as it's required. So when you look here in this part of the NHS and you look at the associated community settings, mostly in general practice, our laboratory is a central supply store, and it provides bottles to the wards and the hospitals as you would expect, but it also provides bottles to general practices. And it does so under a pool system for general practice, i.e. usually they wait till they're ordered. And it does so in the hospital against a pro forma of what's expected. So that system, therefore, has a requirement for a certain number of bottles, and when they're not there, suddenly you can measure the number of days supply that you have available. So you can produce a spreadsheet that says how many you have and how many days of the normal rate of use are they there. So when this happened in August, we started having daily meetings. We, that is those of us in the CCG and primary care, joined the hospital. There was no point in having two committees. And we started collecting data about where the bottles were and how much was needed. And we put in place pretty quickly a situation of pushing bottles out to primary care. So instead of asking primary care to ask for bottles, we started looking at what the use had been and just sending them a comparable amount of bottles, of course, against a historical use. So at the beginning, we had somewhere between 3 days and 7 days supply within the store and in the system at any one time. In other words, if we received no bottles, we would run out for some bottles in 3 days and in some 7. The ordering system within region was put in place, and we made some requests for mutual aid. And so some mutual aid came into North Cumbria, and we stabilised there. We went into a push for primary care rather than pull. And after about 2 weeks, we got to a situation where we had somewhere between 7 or 8 days at the lowest amount of some tubes and upwards of 12 plus days in others. Of course, remember, as we use other tubes to replace those come down as well. So we started to see that some of the tubes we had advised people to use that were in greater abundance previously started to come down in volume. So I think that we were making reasonable progress. I think the thing that brought this really to the attention of the governing body, although that people may have been aware of it beforehand, was that the government sent around a letter, and that letter got some media attention. And that letter said something along the lines of, stop doing routine bloods until the 17th of September. Now, it didn't really tell us what was important about the 17th of September. And I and some other people have now a diary appointment for the 17th of September to find out what's important about the 17th of September, because nobody has told us what's important about the 17th of September. So maybe we'll get a letter on the 17th telling us what's so important about the 17th. And that just demonstrates that really we're in a situation where there's not a huge amount of specific detail, not only on how this happened, but on the larger statements about what we should do about it. So we've had this hold, and what that's generated, John, I think it's why I came to the governing body, is that people started to have cancellation of appointments, or their GPs started talking to them about not having their appointments or their blood tests for another month or even longer. And of course, people who'd already had delays because of COVID were just going, hold on a minute. So now there's not enough bottles. When do you think I might be able to get my blood test? And of course, blood tests are the fundamentals of some of the monitoring systems that we use. So it's hard to talk about the monitoring and the long-term conditions without the presence of blood tests. It doesn't really make any sense. So I don't know what may be said in this letter tomorrow, John. If there is a letter, we'll be there ready to receive it though. But we have doubled
the capability of this system in the number of days, and obviously we could double that again by reducing the number of bottles used when taking tests. Now, there are a whole lot of other things we've gone through about how people change the bottles they used, how many tests would be, how many times the lab would use the bottles sampled to do tests, a lot of complicated to and froing there. But we're in the best situation we can be in without a very large delivery of bottles. I don't know, Helen, if you think you've anything else to add to what I've said.
Yes, I think one of the key things is with the push out system, we automatically reduced the percentage that, so if, I can't remember the exact percentage we went down to, but we reduced the amount going out to primary care automatically to help improve the stores. So primary care have had a reduced amount being pushed out to them. The challenge that this has is bottle does not mean test. So in one, there are two bottles that are mainly affected, the purple bottle, which is mainly the full blood count tests, and the gold top bottle, which is a whole plethora such as kidney function, liver function, etc., etc. So it's not a matter of I'll stop doing as many tests because it's related to the bottles, which makes it a little bit more complicated. So what is happening a lot in primary care now is some of the routine chronic disease monitoring is not happening, which obviously is a challenge for primary care because on one hand we're being told to reinstate chronic disease monitoring post-COVID, but we practically can't because we don't have as much blood bottles, and trying to do more urgent related bloods. But if you are sticking a needle into somebody's arm for an urgent blood and you're using a couple of bottles, if they also have routine bloods that need doing, then you might as well do them because you are using that bottle, if that makes sense. So there is the potential to get a little bit of disparity between the message that some people are having. So some people may get their routine because they're having other urgent bloods done, and some people may be being told they can't have their bloods done. So it's a very difficult message to get out, and it's very difficult because we don't know how long this is going to continue. The information coming through has not been specific about that, but we are being warned about weeks and months. So it's a very challenging situation when we're trying to recover from COVID and improve chronic disease monitoring, which may have been challenged during the last 18 months. And as I say, it's not the most easy message to get out to patients because, as I say, if you've got a needle in someone's arm, you're taking a blood, you might as well do everything routine that you need. So challenging.
So
Okay.
Louise put into the comments, I understand a revised testing strategy is expected to reinforce best practice testing standards as the situation stabilises. I expect there will be a whole series of advice to GP and clinics along the idea of best practice and of efficient use and reducing wastage of use of bottles. And this in of itself is not an issue. Quality and continuous improvement, that's fine. I think the fundamental issue here is just how long is this going on for? And this could be going on for quite a bit longer than people would be comfortable for it to go on for. I have, at worst case scenario, seen some information to say this could go on for a year. And every now and then I hear a very positive bit of news. It's about to finish next week, and everything in between. So as I say, John, it's a very operational matter, which does cause changes in people's experience of healthcare because of the way clinics are run. We could spend, John, and I'm sure as chair you won't want us to, extremely long periods of time going through what we go through in those urgent system logistics meetings, but my own advice here to the governing body is to note the verbal report that we're given. It's a dynamic situation. We're going to have good days and bad days. The resilience plans and the mutual assistance plans are in place. The modifications that we can make are in place. But I expect there will be a great deal of concern from ordinary people, a great deal of frustration by ordinary clinicians, and a great deal of missives going backwards and forwards about what other people elsewhere think we should do about it. It is frustrating, and I think it does require a judgment by us all here at meetings at this level about just how much time would be reasonable for us to spend going through all of the issue. Thank you, John.
Okay, thank you, Colin and Helen, on that. So I'm just going to open it up. Is there any questions or comments from anybody that people would like to raise? Okay, as I say, we brought it here because it was national news, local impact. We just wanted people to make sure they knew, and on top of everything else, it's almost like, is there anything else you can send on top of all of this? So and again, thank you for the work that both of you are doing, and I know that's within a wider framework, but I'm certainly got the message there that there is work going on to manage this process in lots of different ways, and that we appreciate that work. Okay,
there may be press reporting on whatever new letters coming out. I have a funny feeling that that letter may contain other constraints, though they may be expressed in the way Louise stated. But the fact is that even if we talk about best practice, it may still mean that your friend, your family member may not get the blood test they were expecting to get. And that may occasion letters to MPs, letters to us, because it's really hard to explain how the minutiae of this supply system it links to your feeling that your healthcare is not being properly addressed. Thank you.
Yeah, fair point, Colin. I'll finish on that. So thank you so much for that input and that update. I'm going to move on to item 8 now. It's about the Penrith Urgent Treatment Centre. And I'm going to welcome Barbara Fleury, who's the Emergency Care Service Manager for NCIC. And thank you so much, Barbara. And thank you very much as well for actually reaching out to us, rather than sometimes we feel we reach out to NCIC to find out what's going on. You actually said you'd like to come and give us a verbal update about where you are with the public engagement around the proposed changes at Penrith Urgent Treatment Centre. I don't know if they're now embedded or whatever, but I'll let you tell us, Barbara, where you're up to in terms of that engagement. Thank you.
Okay, yeah. I'm not sure if you're aware of the proposal or the background to the proposal, so I'll just give you a little bit of an overview. So currently at Penrith Urgent Treatment Centre, we have services 24 hours a day, 7 days a week. And certainly over the past 2 years at least, we've had significant staffing challenges at the Urgent Treatment Centre, which make it increasingly difficult to maintain safe staffing levels, particularly overnight. I think about 2 years ago, the proposal was first made to withdraw the walk-in service overnight, allowing resources to be concentrated during the day when we've got much higher numbers and much higher levels of activity. But nothing actually, although I think the full consultation happened at that time and agreement was reached, nothing was implemented. So the situation's continued to deteriorate as far as our staffing is concerned. But we thought it was a good idea to reinvigorate the engagement process, to make sure that everybody's back on board, to make sure that we can listen into the community and their issues. So we have undertaken a 4-week engagement process with the community of Eden and surrounding areas. That ended on the 15th of August. We then presented a business case, bringing together all the feedback from the consultation to the SLT, Trust SLT, this week, and that will be going to the Trust Board for final approval, with a proposal to withdraw the overnight walk-in service from the 1st of November. Just to give you sort of the detail of that, Chuck will still be on site at the Urgent Treatment Centre overnight, still offering appointments to patients who need urgent care. But by removing the walk-in service between overnight, it allows us to restructure the staffing that we have at the Urgent Treatment Centre, and we will be able to offer a range of scheduled care services alongside urgent and emergency care once that change goes through. There were some concerns in the community. We had a massive response to the engagement process. We've got 639 responses to the online questionnaire. The major points of concern that we had were, well, the major one was difficulty in accessing NHS 111. And it's quite likely that because this wasn't a survey about NHS 111, but obviously it gave patients the opportunity to voice their opinion on NHS 111, and we did get some very strong feedback on that. We met with NWAS last week to present the feedback to them so that they were aware of the concerns that the patients had raised. And we did recognise in that meeting that some of that problem might be around the problems with the Directory of Services. So we've set up another meeting with NWAS to go through the Directory of Services to make sure that what we're describing is actually what patients can access. I think there were other issues that patients raised that we've passed on to them that we can't tackle around delays in answering the phone and waiting times, etc. But where we can improve the service, we will through the Directory of Services. The distance to Carlisle or Kendal was another concern that was raised. And again, I think this tied into concerns about getting help and advice quickly. It was the lack of understanding that there will still be a GP available at the urgent treatment centre. So we're going to do an ongoing communications plan, starting as soon as this is signed off by the board, to make people aware that that service is still available, that they can still get help and advice. There will be some patients that will need to go to A&E, but the numbers accessing the urgent treatment centre overnight at the moment in total averaged about 2 a night. So it'll be a very small percentage of those patients that would need to go to A&E, but we will monitor that obviously closely. There was a lack of confidence that the changes would result in a better and improved daytime service. So again, I think we've got to get those services described very quickly and get communications out to patients to let them know that they are there, that we are delivering them. And there was a concern that more staff should be recruited so the status quo can be maintained. So I think, again, it's all about communication. It's all about letting patients know how much we've done to try and recruit to the service unsuccessfully. And the final query or concern was that the walk-in service should be available until 10 o'clock. It was 8 o'clock in the original proposal. So we've rewritten the business case to make sure that the service is open until 10 o'clock. To recognise that concern. We've had a full staff engagement process throughout the public engagement as well, and our staff are unanimously in favour of the proposed changes. So we are proposing that if the walk-in, from when the walk-in service is withdrawn overnight, we can offer a range of scheduled services. We would do this in a phased approach to make sure that that our staff have got the skills and knowledge they need for each service before we introduce it, and then monitor it closely. Initially, we will have 2 qualified nurses and 2 healthcares from 9 to 5, Monday to Friday, to offer scheduled care services. We're looking at offering a range of slots depending on the treatments, but we can do things like blood transfusions, IV antibiotics, PICC lines, IV therapy and catheter changes for ambulatory patients. Those would be available immediately, and then in the longer term, the plan is to look at the estates to increase the capacity and offer a wider range of services once the estates and the skill base and the staffing is all ready and in place. So the idea is that GPs would have direct access to those available appointment slots, and there'd be capacity to manage 8 patients simultaneously from phase 1. So that's basically an overview of where we are, what we've got to. There are some savings in year. We've identified savings in year of approximately £220,000, but it's highly likely that that amount of money will need to be reinvested into scheduled care for the longer term plan to get the estates right and to increase the staffing complement. So I'm happy to answer any questions.
Thank you, Barbara. I'm going to go to Colin first and then to yourself, Charles.
So thanks very much for report, and although it's been many years since I did what was then previously a QDoc-Chalk shift in Penrith, many pleasurable moments with the staff there over the years. It was always a pleasure to go and work in the area and see other than Carlisle patients for a while. Since I was Carlisle GP, it was like a busman's holiday. And even though you've had to give a report in a kind of reconfiguration issue about where best value for the assets we have, which is always a challenging thing to do. The main issue that I would like us all to be clear in our minds with on this is not primarily for yourself, but for us all together, John. And that is that obviously a process was followed here. The public were consulted. But when we change services, are we following the correct framework for that? In other words, and I'm not claiming this wasn't done this way, but just so that we have a very clear mind that when we're changing services, on what basis we do so, what's the legal basis we're doing so, what's the process basis we're doing so. And I think that when people do their utmost, as this service has done, to do the right thing, John, we should congratulate folks in doing that, but also just really as a governing body, have a clear view on the basis of how service change takes place within the proper processes. This is not a criticism, it's just an observation. It's part of our role here, John. Thank you very much.
Okay, I've got numerous hands, and I just wanted to just check, because I want to deal with this point, because I think this is a fundamental point. And was it yourself, Peter, who put your hand up probably in response to that? Is there something that you wanted to mention in relation to that process? Because if there is, I was going to bring you in now.
I do, if I could, Chair. Thank you. Thanks for the description, Barbara, and it's lovely to see you. Hope everyone's well. I just wanted to reflect that from my perspective, Julie may have been about to make a similar point, that the NCIC Trust, working with partners, I think have done a really, really good job of engaging with the local practice, the team who work there, the population in Eden, some of the public representatives and so on. The Trust have taken great care in developing this proposal. In fact, truth be told, Barbara would know this. You know, this proposal's been around for a long time, but wasn't acted upon until the right stakeholder engagement could be done. So I would just kind of commend the work NCIC have done. I think it's been a really good example of engaging people to come to the right solution. And from an operational perspective, my own view is this is 100% the right thing to do. So I think Colin's right to make the point about we should always be assured and confident a good process has been had. I would wish to offer some reassurance to governing body members that in my judgment, that has absolutely been the case in this example.
Okay, thanks, Peter. Charles, you're the first one, so I'm gonna go Charles, Julie, Deb, if that's okay.
So I think it's also important to flag, while the right process is followed, we've actually taken a very, very sensible decision here. And when we're talking about resources, meaning our staff collectively, who are a scarce commodity at the moment, it's one of our priorities, and having people engaged to see 2 patients a night doesn't really sound like a very good use of their time. So I think sometimes what we're not actually very good at is making points like that very, very clear. And we have had other instances as an organisation when we covered the whole of the county where we had similar things. The other thing I'd just like to say is I was going to raise, but it's good to see you engage with NWAS. And it's quite interesting, isn't it, how when we consult on things, people quite often respond about something else rather than the issue that we're talking about. But just for the governing body's awareness, just to say, nationally, the problems with 111 have been recognised, and NWAS received some emergency funding to try and boost the capacity of 111. And there's also been an exercise undertaken as well, which comes back to the earlier discussion about primary care and where people using 111 early in the day because they couldn't get through to the practice, and therefore that was just clogging up access to 111 all the days. But just to say, that was reviewed all across the NWAS patch, and there weren't any Cumbrian practices or North Cumbrian practices, I should say, in the top cohort. So I think coming back to the point made earlier about primary care, that's a positive as well. So apologies for not actually talking about the decision, but I think it's important that the governing body can see there are links to other services, and it's the trust to be congratulated in making those links as part of the process.
Thank you, Charles. Julie?
You can probably imagine what I'm going to say, but the importance of involving people when you make changes to services can't be underestimated. And you're absolutely right. NCIC did a great job of this and worked with all of their partners. We worked really closely with them on the first round of engagement. And I will say it was engagement rather than consultation because of all the legal issues around it. This wasn't ending a service, it was changing the way that the service was accessed. And all of those conversations involved staff that were running the service, explaining the pressures, explaining what they thought would work operationally better. And when people had the chance to hear directly from clinicians, it was really obvious to them it was the right thing to do. But NCIC didn't progress it during COVID because that wouldn't have been the right thing to do. And when things calmed down and came back, they said, we need to go through this again, make sure the right people are still involved and still understand. And the really important reason for engaging is because you get feedback that you wouldn't normally get, and it allows you to make your service the best it can be. So to hear Barbara say that the community's come back and said, actually, we prefer you to be open till 10 rather than 8, and to be able to respond to that is brilliant and is exactly why we engage with the community. To pick up all those different challenges around 111 and then to have those conversations with NWAS and to see that actually there might be something that you can do about some of that, and to have those relationships where two different organisations are working together to make it better for our community is exactly why we should be engaging. And it's really good that the approach was really collaborative and involved the CCG, it involved NCIC, it involved our community forums, it involved the League of Friends at the hospital, it involved our primary care teams, and gave everybody the opportunity to say, if this had been something that had been done with no opportunity to have those conversations, the headlines would have been very different. And the fact that the staff are excited about this means that the patients will be getting a better service in Penrith when it's enacted. And I think Barbara and the team have done a fantastic job. And Colin's absolutely right. We should always be asking that when things change. So it's the right thing to do. Thanks.
Thanks, Julie. Deb?
Yep. In fact, Julie's answered my question, which was, what could we learn from why it didn't happen the last time? But obviously it was COVID. But I also just wanted to add my congratulations, Barbara, to you and your team, because we know that change and improvement isn't easy, but you seem to have done it really, really thoroughly. And therefore, there is an outcome that is better for patients. And that's what we want, isn't it? So thank you very much for all your hard work, because I'm sure at times it was not easy.
No, not always, but we'll get there.
Thanks. And can I just step through a process, which I'm going to be very governance in here, is that one, I know that Health Scrutiny Committee were involved in the discussions as well. So there's been conversations with Health Scrutiny about what you've been doing. That's correct, Barbara, if I'm not. Yeah. So there was, if you talk about a process, there's a heavy involvement there. Two, because it's not a significant change to services, in the way that, should we say, the CCG would be involved in terms of our consultation. It's a decision done in partnership, as you've just described and Julie's just described, but it's not a CCG decision. It's a decision for the trust to be able to vary that. That's correct. Is that right, Barbara? I'm looking at my colleagues as well. It's not something. So it's not. We're just being told about this because it's the right thing to do, and actually you're just engaging with us as well as a big key stakeholder in this. So I want to thank you for that, Barbara, in terms of how it's done. And again, Julie will know I was involved in some of those early discussions that took place, and the people involved in it and their willingness to try and do the right thing was evident, and I know that Julie was very supportive in terms of the experiences you've been through, Julie, on behalf of our organisations and what we've been through to try and make sure the right way was done. So yeah, so if you could just sort out the ambulance at Alston now, Barbara, which is nothing to do with you, I'd appreciate it as a Penrith resident, but there you go. Okay, so is there anything from anybody else that people wanted to raise? No. Thank you, Barbara. Good luck with the endorsement of the decision when you go through your board. But I'll say, I think what you've got from here, from us as a governing body, is very much supportive of A, what you're proposing, and B, the work that you've done to get there.
Excellent. Thank you very much for the opportunity to come and talk to you all.
Okay, thanks, Barbara. Take care. Bye-bye. Okay, going on to item 9, and there's a paper on this is from yourself, Charles, CCG assessment and NHS oversight framework.
Yes, so having actually talked about something that I think was quite interesting and we can all relate to, we now go into a bit more NHS bureaucracy, sadly. But I'm not going to spend any time talking about the 2021 assessment because Mark picked that up in the earlier item. So if people have seen the oversight framework that's been established, I think what this does is really signal very strongly the direction of travel that about getting systems to work in an integrated way and trying to assess systems as systems rather than as a bunch of disparate organisations. So that's the ethos behind it. In Appendix 2, what we've done is taken the actual detailed performance things. We've tried to, it's just a cut and paste from the national guidance, but we've added another column in to see how can we ensure, if this is what we've been asked to do as a system by, if you like, the powers that be, can we link that work to our 5 system priorities that we've defined locally? And I think this is just the CCG's interpretation of that from some of our colleagues, but I think they made a good fist of that. And what we're doing now is some work through our programme review group to look at how we monitor some of these things. Some of the information we cover through the performance report, which we'll see later on already. Other bits are picked up through the work of the Quality and Outcomes Committee, so we can see those are there. And there are other bits that particularly those relating to primary care, are also covered. But I think we've asked the group to see, just is there a better way when we've got all that information? A, is there anything on that list that we're not looking at that we should be looking at? So we do that, and then should we refine any of our existing reporting processes to make that more straightforward? I've also included on the report how CCGs will be assessed for 21-22, which, as it said, is a sort of continuation of the 2021 arrangements. I think the sharp amongst you might have identified a slight flaw in this process, in that when we will know whether we've achieved those performance indicators, if the legislation goes through, quite who will be involved in that conversation and meeting about the CCG's performance when it might not exist anymore. But I'm sure cleverer people than myself have got an answer to that. And that doesn't mean that we're not going to be taking these issues seriously. So apologies for being facetious. The key issue is we look at those priorities and use our best endeavours as a system to deliver on those. So that's all I intended to say, really, John.
Okay, thank you, Charles. I know you were keen just to make sure people were aware of this, what the process is, what the documentation looks like, and those brief updates. Thank you. Are there any questions or comments from anybody that we'd like to raise now, other than the fact that we're aware of it and we know it's happening? Yeah. Okay. Right, no, I'm not going to prolong that then. Charles, thank you very much for putting that in front of us. I think it's very important that we do know that. We'll note that then, and then we're going to move on to, excuse me, the next 3 reports, which I think have seen, should we say, some airtime at either the quality and outcomes or finance and performance. But I'm going to start off with yourself first, Louise, with the quality update and the report you've done there.
Thanks, John. I was just going to ask first if it's okay. I would like to provide a really brief update in response to the Corsten report. So I'm happy to do that after the quality report or under any of the business, John. So if you could just let me know your preference.
Do it after this section then, Louise, if it's okay.
That's great, thank you. So obviously colleagues will have read the report, and I think as we've already heard today, this reporting period has been marked with challenges linked to the ongoing demand for health services and the impact on the flow of patients and access and the delivery of services as a direct result of the acute staffing pressures, and particularly in the social care sector. And as Mark referenced earlier, in domiciliary care. This has had, it's taken a significant amount of work to make sure that individual clients have been safely supported, which we have managed. This obviously has impacted in other areas in relation to the capacity and the provider failures. And I think it's probably worth noting that these provider failures are occurring in areas that we wouldn't usually see. Obviously, we are aware of the challenges in some of our rural communities, but these provider failures are happening now in our quite heavily populated areas, for example, Carlisle. Again, it's not just domiciliary care, it is also affecting care homes as well. So you will note in the report that we have refreshed with the local authority our joint provider failure. And at the moment we have 3 homes in what we call a formal quality improvement process, 1 domiciliary care provider and 1 supporting living provider as well. The dashboard therefore again also reflects the impact on the constitutional targets. I will also note obviously in relation to what has now been the newly released trajectories for C. difficile and the gram-negative infections. We're already indicating red on the dashboard. Obviously, this is raised in the performance report, and we have regularly reported this through the quality report. That despite the work that is ongoing to address this, we're clearly not on target for that trajectory. We talked about COVID. There are still 5 outbreaks in care homes at the moment as well. So again, I think it's worth referencing that in terms of these overall demands, it is having an impact on the wider services, in particular for us, our CHC services. I haven't got an actual time in terms of hours that staff have had to take during these provider failures to work through and provide that necessary support, but it has been substantial. Just in terms in response, again around the quality assurance issues to do with discharge, the CCG has now offered some mutual aid support to the Transfer of Care Hub and the system coordinator to help keep that focus on improving quality and patient experience while we go through these really challenging times. Other than that, I'm happy to take questions on the dashboard, John. Thank you. I don't know if Carol wants to add anything.
Yeah, I was going to ask Carol, is there anything you wanted to add before we opened it wider?
No, I'm fine. Louise has covered everything. Thank you.
Okay, thank you for that. Any questions or comments from people? As I say, I know this has been through your committee, Carol, already. Are we okay? We're asked to note the report. Yeah. Okay, we note it. We note it sadly, but we note it because, as I say, we know the work's ongoing, and it does sort of link over into the performance report now, which I'm going to move on to. Obviously, Charles, just anything you want to pick out there, and of course, we spoke about this yesterday, really.
Yeah. So, thanks, John. So just to clarify, So this is actually, so yesterday we spoke about in finance performance the August report. This is the July report. It's just because our meetings are a bit out of kilter at the moment, but the reality of the situation is actually, as we talked about earlier in the meeting, the figures are very similar. What I would just draw people's attention to is on the actual report itself, page 3 of the constitutional standards, because I think this is quite a useful barometer, being ambulance performance, of how pressured the system is, and over the years since the new standards have come in, at the end of March 21, apart from the Cat 1 average time being the 7 minutes that we say, when you take the geography into account, is very difficult to achieve, North Cumbria CCG last year achieved all the other standards. Sadly, for the latest month here, and it continued into August, we saw a similar picture. But I would just ask colleagues to have a look a bit further across and what the average were for the whole of the NWAS patch. And when you look at the position in Cumbria, while that's very challenging, actually, that if you look across the rest of the patch, how challenged those areas are, particularly Cat 5, with the average across the northwest being 13 hours. Now these are for the least serious patients, but it just shows how challenged the system is, and I'm sure Mark would observe through his discussions in our ICS that we might not be seeing an exact back-to-back of these issues, but in the northeast the system is incredibly challenged as well. So I think when Carol was talking about being assured people are doing the best, I think what I'm just highlighting here is people are doing the best in what certainly across the northeast and northwest of England is an inherently very challenged situation, and in that respect North Cumbria is by no means unique, and obviously this is having an impact on lots of services, as we discussed previously. So I don't want to labour the point, because I think we've had quite a significant discussion earlier on in the meeting, but I just actually thought it would be helpful to draw everyone's attention to that, to say this just isn't an issue for North Cumbria. It is a much wider issue, and while there's not a lot of solace in that, it's really just to give that assurance that we are all trying as hard as we can to address this, and the outcomes we're seeing in our area, we're not the only place with these issues. And I think just to get an appreciation of where we are is hopefully quite a helpful approach.
Okay, thank you, Charles. And I suppose from my perspective as well is that as Chair of Finance and Performance, when you look at the issues themselves, particularly around A&E and or cancer, or the recovery, the treatment to referral and electives, there is work ongoing to, through a governance process to sort those things out. Sometimes it's not shifting stuff, sometimes it's even going worse for different reasons, but it's not for the want of trying to achieve it. It is what I'm saying on that, and it's frustrating and it's upsetting, particularly for the patients. Deb?
Yeah, I just wanted to ask in relation to the cancer performance, what impact will the new cancer centre have on the performance to benefit our patients?
Well, I think Peter can probably answer this much more eloquently than me, but I think that there are some just very practical points, like having new equipment that is much more fit for purpose and enables a better quality of care. I think the other key issue, particularly in these much more specialist roles is the amalgamation with Newcastle Hospitals, and Newcastle Hospitals being the lead provider for their clinical services. They can get much more synergy with their teams, if you like, that are based at home, and it improves the ability to recruit key staff, which inevitably improves access to the service. So there are some very practical things that probably, I would imagine, actually going back to some of the previous items about working in a more integrated way, that this is the bit about providers working collaboratively and trying to put the specialisms where they're most appropriate to give best benefits to patients. And certainly we had a meeting with our North Cumbria Integrated Care colleagues, senior team, earlier in the week, and their view was the transfer had gone well. There'd been one or two teething problems, but generally patients were getting a much better service in an excellent new facility. I don't know if you want to add anything to that, Peter.
I think you covered it really well, Charles. On the precise point about what will be the performance benefit, well, that will come in time, Deb. I guess we'll see in time. But in the way Charles just summarised, it's a fantastic environment. It's a shame everyone can't go visit, but you can't for obvious reasons, you know. Fantastic environment. The quality and precision of radiotherapy is enormously enhanced, and Deb, you would understand this in ways that I never could, but the precision now to target the appropriate places and avoid damaging the surrounding areas is hugely improved. People will need less fractions in some cases. People won't have to travel to Newcastle for some of the fractions they previously did have to travel for. The relationship with Newcastle is really beneficial, including clinicians working remotely through appropriate technology that's now in place from Newcastle rather than having to come over, etc. And the experience should be a lot better. There are challenges about the connection between the Newcastle part of the pathway, the North Cumbria part of the pathway, and indeed the general practice parts of the pathway, and for good survivorship, etc. So still lots and lots of work to do, but it's a fantastic thing. It's a fantastic thing. And without it, you know, there were some real concerns and fears about the sustainability of the previous service, which are a matter of public record, really. So it's a positive to cling to, for sure.
Great. Thank you very much for your thorough responses, and it's good to have some good news. Thank you.
Thanks, Deb. Julie?
I was just going to mention, if it is okay, that there's actually a bit of work going on now to set up a North Cumbria Cancer Patients Collaborative, name still to be decided, but we've kind of struggled with that patient involvement around cancer services, and stars seem to be aligning, and there's been a couple of really very positive meetings, which is really positive and much needed, and will help with improving services. And I also just mentioned, David might want to come in at this, but I know that People First have taken over the cafe area in the cancer centre. It's due to open quite soon, and just in terms of that collaboration between a very important new health service and one of our local providers who are going to be offering training opportunities within that, it's a really positive thing to see happening at the CIC site.
Okay, thanks, Julie. Okay, is there anything from anybody else before I move on? Or I'll move backwards, actually, because having been told something 2 minutes earlier, then forgot it. So I was just going to move backwards, actually. Louise, I said you could talk about the Corson report, equality. So sorry I missed you, but back to yourself.
It's all right, thank you, and apologies, John, for introducing something that wasn't on the agenda, but I just wanted to take the opportunity, really. Colleagues will be aware it's been in the national press around the publication of the Safeguarding Adults Review in relation to the deaths of Joanna, John and Ben at Corston Hospital. Without necessarily going into the detail, I just wanted to highlight really and offer the assurance. The recommendations from that report included just reading them, that the CCGs need to be proactive in showing they've got up-to-date knowledge about the services they commission. There is recommendations about ethical commissioning and for reviewing people's placements and addressing the racism of people with cognitive impairments. There were some immediate actions which were around regular commissioner visits, improving the reporting of the visits and improved due diligence when making the visits. In a sense, I'm not saying it's timely for the wrong reasons, but we did have a fairly comprehensive report for the first time, which also went to F&P around quality assurance to do with complex cases that we commission. And again, just to provide that assurance to the board about what we do have in place for individuals with learning disability and autism, is that we do have a programme of oversight visits. We do have a programme of host commissioner visits, and these are for assessment and treatment units in our area. We do liaise closely where we've got host commissioner visits for inpatient units where our residents are placed. We are commissioning experts by experience to assist with those host commissioner and oversight visits, as well as the ongoing submission of data to NHS England. And finally, we're involved in those regional conversations about widening out the oversight of visits as well. So I just wanted to take that opportunity for this board, John. Clearly, there will be a whole set of recommendations that we will need to report on subsequently. But as I say, just wanted to take that opportunity to offer that reassurance to the board. Thank you.
Okay, thanks, Louise. And I take it you'll take those other issues through quality and outcome meeting?
Yep.
Yeah, that's okay. Yeah, no, that's fine. Thanks so much for that. Okay, I'm going to move us on unless there's any particular questions on that. No. Charles, finance report.
Thanks, John. And again, a bit like the performance report, we actually discussed the more up-to-date report yesterday at the Finance and Performance Committee, but I'll just give some headlines. So for H1, the position at the end of August was actually very similar to the position at the end of July, which you can see in here. And we remain confident that we will achieve our financial target agreed through the ICS and with NHS England for the first half of the year. An observation made yesterday was that it wasn't particularly helpful that as we are 2 weeks away from the start of H2, we don't quite know what resources we've got and what we're expected to do, but I'm sure it won't have escaped most people's notice the big discussions over the last couple of weeks about the settlements for the NHS and social care going forward. But actually part of that settlement was funding for the NHS for the remainder of this part of the year. So at the top of the shop, as it were, those discussions have definitely been going on with Treasury colleagues, and therefore only after the NHS has its confirmed funding can it then dish it out, for want of a better phrase, to the various systems. So we're expecting to hear something formal about H2 next week. What's being trailed, and I think it's appropriate to share, is that some of the arrangements that have been in place in the early part of the year will continue. A key one, which going back to the performance and challenges in the system, is the continuation of the hospital discharge programme that provides funding, universal funding for people discharged for the first 4 weeks after they leave hospital, which hopefully helps smooth things out and means patients can receive appropriate placements without a lot of issues about the funding, either for themselves or between health and social care, which actually the funding announcement for social care was more about probably those funding arrangements rather than actually the mechanisms of working with social care providers which we expect to come out a bit later on. We also expect there will be continued support for the elective recovery, which again, as we look at the performance report, and while we have made reductions in from where we expected to be of 52-week waiters, we've still got a massive problem, remembering that 18 weeks was actually the formal target prior to COVID, so a big challenge there. We also expect, as part of the arrangement, there will be more of a focus on efficiency in the second half of the year rather than the first half of the year. And I think my view is, as a system, while we do have some measures in place that we're working on, we may need to take some one-off sort of decisions to balance the books in the second half of the year, because clearly a lot of focus is going to be on delivering all the service issues. And that, again, I don't think is an issue that's unique to North Cumbria. And certainly at a meeting I was at with colleagues from the other 3 ICPs in our ICS, we were giving that message back to the Regional Director of Finance that the system is very pressured at the moment, and therefore we need to engage in a sensitive and sensible way without forgetting about the finances with our staff. Many of the reasons, again, that have been articulated earlier in the meeting. And that leads us on to the third point, really, which is to say, at some point, in a lot of ways, hopefully, well, in all ways, hopefully soon, we'll be moving much more towards a business as usual position. Quite how many of the COVID rules and working practices that will stay, we're not quite certain. Some of those, actually, there will be things we can learn and do better, but some of them, just on things like infection control measures and things, by definition, slow through the throughput of patients, say through operating theatres and such like, and rightly so. Those are there, and that's what we've got to keep an eye on. But we expect, as part of that national settlement, people have heard sort of the first 3 years is about sorting the NHS out, and therefore probably around November time we'll start hopefully to see the guidance for the next few years about how it works. And in the background, as was no secret prior to COVID, North Cumbria was a financially challenged system. So when we move out of the current sort of emergency regime, there've been no magic bullets, and a lot of those challenges are still there, and we will need to do something about those. So that's something that we're looking at the moment, but more to build into the planning for 22-23 rather than the last 6 months of this year. So I managed there to do a finance update without really providing any figures, but I think that hopefully gives more of a sort of flavour of the issues that we're looking at and the work we will be doing over the coming months.
Okay, Charles. I mean, figures are available on your report. You're just illuminating the report the way you can.
Yeah, they are. Yes.
Okay, right. Okay, is there anything from anybody that people want to pick up? No. Okay. Right. No. As I say, we'll keep moving on. So thank you. We'll note that report. We're going to go through item 13 now, which is just sort of generally the minutes of the committees and accepting those, but also as well giving any of the chairs the opportunity to raise any issues and obviously members of the governing body to ask about particular things. And I know some of these are dated, but that's just the nature of where we are. So I'm going to go through Exec Committee first for the 23rd of June and the 28th of July. Mark, anything you wanted to pull out from that you wanted to raise, or just no? It's okay.
Not in particular. I think it speaks for itself.
Okay, that's fine. Anything from anybody? No. Okay. Finance and performance, 16th of June, which is myself in terms of chairing. I've got nothing to raise. Anything from anyone? No. Outcomes and quality, Carol, 7th of July, anything you wanted to pick up? No? Everyone happy? Yeah. Okay. The Primary Care Committee, again, back to me, 16th of June. The only thing I want to raise here was just to note, really, just the revised arrangements which the Primary Care team have done for quality improvement and the sort of funding process for that. I think it's just important to just to note that and be aware that they've done that scheme and changed it, or they've not changed it, they've changed the arrangements for how you get the money for that. Wider system stuff. Health and Wellbeing Board, 2nd July. All I was going to raise from there is just for people to know, there was reports there about the emotional wellbeing, resilience and mental health of children and young people, strategic plans, and also as well as we do get at every meeting is the SEND improvement update. I just think it's, if people want to have a look into that, have a look at that. Anything from anybody on those? No? Okay. ICP Leaders Board, 1st of April and the 3rd of June. I just wanted to make a couple of links for people there, just in terms of one, awareness of the Local Resilience Forum recovery strategy for Cumbria, which the council lead on, and some of the connectivity between the items on that, which is not just about health and care, it's about the wider economic issues as well. But there are some health and care issues for us to connect up to on that, and the Health and Wellbeing Board joined those up. And as well, two really good presentations, if you get a chance to read the notes on this. One from Active Cumbria in terms of the work that they're doing across the board in terms of people keeping active and looking after themselves, and what their strategic plan is for the next 5 years. And also as well, although it is difficult at the moment about the discharge process, there was really good presentation about the partnership approach to discharge on the meeting there as well, which is, I think was, you know, you're talking about right across the board, social care, GPs involvement, trust involvement, everything. So it's a good process. It's just struggling at the moment because of capacity, shall we say. I've just noted that, Carol. Yes, it's John. I asked the minutes to be amended. Okay, I'll make sure they are, Carol. Sorry, thanks. Then the other one, just joint committees. No public meetings have taken place. So everyone okay with those? Yep. We haven't got any questions from members of the public that I'm aware of, Brenda, unless you've received some after the start of this meeting. Oh,
no, I haven't, John.
No, and I don't think we have anybody present from the members of the public that I can see. Okay. So I take it we've got nothing on that item. Yeah. Okay. Any other urgent items of business? I did have a word with Charles. Charles is just going to talk us quickly through due diligence and the process of the CCG shutdown and the process for managing that, which he touched on at finance and performance. So Charles, I'm just going to pass to yourself.
Yeah, thanks, John. So it's a bit of a strange one because due diligence is normally something you do when you're taking something over rather than being the sender, as it were. But clearly, in the ethos of the NHS and the public sector, that's really relates more to the commercial sector. And actually, in the lead up to the ICS developments, CCGs have been asked to complete what's called a due diligence exercise to make sure that the new organisations, subject to parliamentary approval, of course, have all the relevant information passed over from all CCGs to the new organisations. There is going to be a report about this process that colleagues, Dan Jackson, who's sort of leading the governance work stream for the ICS, is going to do a universal paper for all CCG governing bodies to consider. But in terms of the practical point of view, we felt this is actually quite similar to the work we did for the boundary change, in that we prepared a lot of information to transfer over to the new Morecambe Bay CCG from the then Cumbria CCG, and we got a small project team to oversee that. We're going to do this mainly through the programme review group, but for oversight and assurance on the process, as with the boundary change, we felt the best place to do it was through Finance and Performance Committee, and then if there was anything that needed escalating further, it could come to the governing body. But given it's a very transactional exercise, we thought probably the best place that it fitted naturally was under the review of finance and performance.
Okay, thanks for that, Charles. And we, from an F&P perspective, we agreed to accept that. I take it everyone's comfortable with that as well in terms of us as a governing body, yeah? So just note that, Charles, that in terms of that as a process, people are comfortable that we'll do it through there. Okay, so thank you for that update. I've just got down now the date and time of next meeting is obviously Thursday, the 17th of November. We are endeavouring, and I use the word endeavouring, to get a face-to-face meeting for that, but also trying to do it as a hybrid. I know that Brenda and I have been trying very hard. I know David's gone off the meeting. Oh, in fact, I think he's come back on again. Is that we Healthwatch appears to be one of the only locations in terms of the People First premises that they have in Carlisle where you could do it, but due to demand for that, it's been full up. So we are working to try and achieve that, but it may well be that we will endeavour for a face-to-face meeting. And I know that actually just this process does cause some difficulties for people who are actually at Park House, and being, you know, it's a challenge in terms of meetings of this size when you're in an open plan office. Anyway, that's what we're aiming to do. So I don't want to sort of prolong this, but we've got a meeting coming up again in another 10 minutes. I'd suggest we have a 10-minute break now. Get yourselves a drink. I've got it down as 14:55, so I have finished on scheduled time. So I would like to start at 3:05 rather than give ourselves an extra few minutes. But so if we could come back at 3:05, we're going to be on this system, so it's just to bear that in mind, and just we'll do the part 2 then at 3:05. So thank you very much. So just shut yourselves down in terms of camera off and video audio.